Yes, I'm ready.
Yes, sir. Just give us a minute. We are going live.
Okay, sure.
It's sharp 11:30, sir. So with all your due permission, we are beginning with the session for today.
Yeah, sure.
Thank you so much, sir. Good morning, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. Well, sir needs no introduction at our platform, but yet it's our pleasure and honor to introduce him. He is none other than the very renowned endocrinologist, Dr. Anirban Sinha sir. Sir is MD, DM in Endocrinology, FSE, Associate Professor at the Department of Endocrinology at Medical College, Kolkata, Visiting Consultant at Amri Hospital, Chairman Ethics Committee, Central Hospital, SCR Program Chair, and MMSc Endocrinology at Texila American University.
Yep.
Excuse me. With the help of sir, we'll be talking about the topic for today's session, which is syndrome of inappropriate antidiuresis. Before moving on to today's session, let us have a brief look on what the topic says. When SIAD is a medical condition characterized by an abnormal release of antidiuretic hormone leading to excessive water retention by the kidneys. This results in dilution of body fluids and electrolyte imbalances, potentially causing various health issues including hyponatremia and neurological symptoms. Understanding and effectively managing SIAD is crucial to restoring fluid balance and ensuring the well-being of affected individuals. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his enriching talk to begin. Sir, over to you.
Thank you. Thank you for inviting me first in this August forum to discuss a very important topic we see maybe in the patient care in the slightly in hospital setting. SADH, honestly, the syndrome of inappropriate antidiuretic hormone is honestly does not come by its name flagship on the patient. So what the patient normally present is with persistent hyponatremia. And it is very important to understand that whether the hyponatremia is SIDH or not an SIDH. So I will try to better delineate in the clinical aspect of that presentation. That is the presentation of the SIDH, mostly with hyponatremia, and that how to approach that hyponatremia. And subsequently, we'll discuss the SIDH, the physiology, and the management issues of the SIDH. So with this, the hyponatremia, one of the very common electrolyte disbalance in human being, maybe mostly in the elderly or even in the middle-aged. So we approach that with a rationality to get a good outcome and find out the disorders. Sure. So with this, I start with the following agendas, like background, pathophysiology, clinical features, and classification, diagnostic approaches, how to approach that. There are guidelines as well, and there are management options. There are recommendations of treatment, and there are special situations like pediatric population, very uncommon, but important to handle it, especially for us as an endocrinologist or as a elderly population or other serious situations. And lastly, we'll have a take-home message. So 70-year-old. So this is actually starting with case, so better understanding the situation in real life. So it is a 70-year-old lady brought to the emergency room with a day of confusion, nausea, vomiting. She was started with the clothalidone 25 milligram once 1 week earlier to treat the newly diagnosed hypertension, very commonly used antihypertensive for the patient. On examination, temperature was normal, heart rate was slightly high, respiratory rate 14, saturation 100. And resuscitation, patient is acutely ill, appearing not to be oriented in the time, place, and person. Mucous membrane was dry, no volume overload seen. So saline infusion started to 1 liter in 24 hours. And lab results shows sodium was very low, that is 104, potassium is 2.8, blood urea nitrogen is 27, creatinine 1.4. She had a generalized seizure episode as well. So what is the management? So that triggers us to approach the patient of hyposmolarity and hyponatremia. So start with in the background that hyposmolarity is the most common disorder of the fluid electrolyte in the hospitalized patient. Plasma osmolarity can be measured directly by freezing point depression, which is not available at present in most of the hospital, but labs have definitely help. Vapor pressure plasma indirectly by the equation, what we commonly do in our clinical practice, that we can see this equation here. That is the osmolarity. If other indigenous osmoles or abnormal osmoles are not there, so it is 2 into sodium plus glucose by 18 plus blood urea nitrogen blood by 2.8. So that is the importance of having the blood urea nitrogen in the previous patient we have discussed. Therefore, the sodium plays a very important role in the determination of the plasma osmolarity, and any perturbance, any abnormality in the sodium, we can see the 2 times the sodium. So it is affect almost the double the effect of the sodium low and low levels of sodium. And however, the after mentioned techniques gives an idea of total osmolarity, not the effective osmolarity. So because this equation has some errors, so there are other indigenous osmoles or other components which also affects the osmol, which is not taken into calculation to avoid it make more complicated. So otherwise, this is a very working approach of measurement of the osmolarity. You can easily use it in your clinical practice to confirm the pathogenesis. Water homeostasis is the basic pathophysiology. It moves freely between the intracellular fluid and extracellular fluid. If the patient is normal, physiologically normal, no disease there. So normal situation, total osmolarity is equal to the intracellular and extracellular osmolarity. And how do we measure the osmolarity? In the very simple term, maybe it is solute by total body water. May it a total body water that includes both intracellular as well as extracellular fluid. And hypoosmolarity can happen in the 2 situations. So we can understand that either in the equation, either the solute can be low or the body water can go up. What are the situation? Like solute loss, that can be aggravated by the hypotonic fluid. As we have seen this last question, diuretic induced osmolarity or excess body water can be because of the excess water intake, maybe a compulsive water drinking or other reasons of excess fluid intake. So fenestration in the basal blood-brain barrier is actually there to allow the plasma to access the osmoreceptor cells, the subfornical and organ vascularism, that we understand these are the osmoreceptors where it lies there. Osmolarity rises. What happens? The hypothalamic nuclear depolarizes because of the stress-sensitive cells. They actually stimulate the supraoptic and paraventricular nuclei, thereby release the vasopressin and posterior pituitary. So this is the basic mechanism how the vasopressin is secreted in the pituitary, or it maintains by the balance of osmolarity. Osmoreceptors are solute specific, and vasopressin leads to increased recruitment of aquaporin 2 channels in the distal nephron and thereby increase the water reabsorption. ABP forms the parvocellular neuron, aids the aid in ACTH secretion as well. So it is a dual, it also affects the ACTH triggers as well in the other ways. It is a very complex physiology. I'm just going in a nutshell maybe. So we can see here the water content of the blood is too low. It stimulates here, high volume of the water reabsorbed by the kidney, small volume concentrated urine passes in the bladder, and high volume of water passes into the blood. So we can see the osmolarity rises. So it should be more than 100. That is the characteristic, one of the importance, so that it shows that it is a concentrated urine. It can be up to 500 as well. So water content in the blood rises. On the other hand, if the too much water was patient drunk, then the water content of the blood is high. It pituitary releases a little ADH, it suppresses it. and thereby low volume water is reabsorbed by the kidney and high volume of dilute urine passes to the bladder. So it can be up to as low as 50. So low volume of the water passes into the blood and most of the water is treated in the kidney. That is the basic way how the physiology of water balance is maintained. So in the kidney, we can see is aquaporin 3 is there here, and water aquaporin to apical membrane and basolateral plasma membrane. We can see the difference, vasopressin signaling, how it is done. Water gets in from the apical plasma membrane and the basolateral plasma membrane, it vasopressin where it acts, and the V2 receptor and aquaporin 3 and 4 are stimulated and improves the water reabsorption. So what is the definition of the disease? So rather hyponatremia, plasma sodium distribution more or less a normal club, as we have read in the statistics. So serum sodium less than 135 is taken as a cutoff, both adults as well as children. Hyponatremia is found around 30 to 40% among the hospitalized patients, and 5% have the plasma sodium less than 130. So up to 130 to 135, that is a mild hyponatremia. People are not very scared, but you should be alert and careful. But less than 130 is a concern. Neurosurgical condition, which is very important cause of hyponatremia, like 50% cases of the CAH and 15% with intracranial tumors, they are the most important cause of hyponatremia. So these things should be excluded if the patient has persistent hyponatremia. What are the implications? Asthmatic hyponatremia previously was taken as a benign condition because slight low in sodium level is acceptable and body adapts it. But these are certain, but we should not ignore it as well, because it is associated with significant morbidity and mortality, especially in the hospitalized patient, even in the mild cases of hyponatremia. But in the severe hyponatremia, defined by sodium less than 125, mortality was 3 times higher than the non-normonatremic patients. So just a sodium less than 125, mortality increases significantly. Mortality was high in those patients whose plasma sodium level falls during the hospital admission. Among the biochemical parameters of acute hospital admission, plasma sodium concentration was most strongly associated with in-hospital mortality. So this is odds ratio of 4.4, that is 4 times higher mortality if the acute hospital admission, if the sodium levels are low. So it can predict the mortality of the patient as well. So this is how the osmolality affects. So normonatremia, this is acute hyponatremia. Sodium level goes up, water increases. So the osmoles in the brain increase the water intake because water is outside the brain is very high. Sodium level is low. That edemata occurs. And chronic hyponatremia, this actually the sodium, potassium, chlorides and osmoles goes out. So it balances out and patient may not have that much of effect. But osmotic deamination occurs when the rapid correction of hyponatremia, which causes glutamate, mannitol, and acetyl, which are the edogenic osmoles, which can actually increase the edema of the brain, and that is called osmotic deamination if rapid correction is done. So there are clinical features. Rapidly fall in the sodium is main determination of the symptomatology. How fast the fall is there. If there is a slow fall of 132, 135 to 130 in about 7 days, patient may not have some symptoms. Occasionally headache may be the only presentation, or nausea. But if the patient has rapid deterioration, that can cause rapid fall in the sodium within 1 or 2 days time, that significantly increases concerns. So neurosurgical intervention, intracranial SOL, what cause onset of the symptoms occurs at the higher sodium level. Acute hyponatremia cause cerebral edema, raised ICP, cerebral herniation, can cause hypoxic brain injuries and even cause death if the cerebral herniation is too rapid. So it is a serious concern. And nausea, vomiting frequently overlooked as a potential early signs of ICPs that should not be overlooked in the in-hospital patients. So you should look for at least the papilledema, so look for the ICP rise. And non-cardiologic pulmonary edema can happen, especially is the marathon runners. So this is also another atypical presentation of hyponatremia. So we can see here that according to the levels, more than 125, there is occasional headache, nausea, cognitive impairment, disorientation, abnormal talkings. These are maybe the only presentation. 120 to 125, maybe the nausea, confusion, anorexia, cramps are there. 115 to 120, the patient becomes violent, agitated, drowsy, stupor, anything can happen. And less than 115, there is a chance of coma and stupor, seizure as well. So severe one, they have a vomiting, cardiorespiratory distress, abnormal deep somnolence, coma. There is a Glasgow scale less than 8 is one of the presentation. Look for the casualty. Does it match with the degree of hyponatremia? Classification, hypovolemia. This is very important to understand that to differentiate other causes from the SIDH, that is the hypovolemic hyponatremia, hypervolemic hypovolemia, and euvolemic hyponatremia. Hypovolemic one is the depletion of the body water and solutes, but the relative excess of the loss of solute. So hyponatremia is there, but the volume is also low. And hypervolemic hyponatremia is that volume is high, extracellular fluid volume increases, but the greater and the solute goes low. But both of them actually increase the relative rise of volume compared to the total relative rise of total body water compared to the solutes. And euvolemic hyponatremia is the impairment of the free water clearance. That is one of the presentation of our patients or SIDH. So volume level remains says, but free water clearance is impaired. So we can see the clinical symptoms here. This is taken from the book. So dry mucous membrane, decreased target, tachycardia, hypotension, raise, urea, renin, and euvolemic one also causes similar symptoms. And hypervolemic one causes the peripheral edema, ascites, pulmonary edema. So these are more fluid overload signs are documented. So we should differentiate it by urinary sodium level, whether the sodium excretion is low or normal. So if the sodium excretion is low, that is less than 20 millimole per liter, it can be because of hypovolemic hyponatremia, because of the GI loss, severe vomiting, nausea, vomiting or diarrhea can cause that, mucosal losses, pancreatitis, or fluid collection in the body, so that fluid loss inside the body cavity as well. But euvolemic ones, mostly the hypothyroidism or SIDH. This is the very important two causes where the serum sodium remains low, as well as but the hyponatremia occurs. But the serum sodium, urine sodium excretion is low, but fluid restriction. But if the patient does not have the fluid restriction, then urine sodium excretion is very high in the SIDH, as well as ACTH deficiency, urine sodium excretion is very high. So this is the way we look at and differentiate the causes and pathogenesis of the hyponatremia. I'm not going in details of other causes, just to say that secondary hyperaldosteronism explains the urine sodium excretion less than 20. So thiazide-induced hyponatremia is one of the serious issues in the elderly, as we have seen in the patient. Adrenal insufficiency is one of the another important factors, mostly in the elderly, as well as cerebral salt wasting syndrome. I'm not again, because we are discussing the SIADH, but there is a very important DD of SIDH is the cerebral salt wasting syndrome. First described in 1950, natriuresis along with the reduced plasma volume is associated with hyponatremia in this situation. And large infusion of saline did not change the hyponatremia, and elevated level of the natriuretic peptides are found in plasma and CSF as well. So this is how it works. But brain stimulate the sympathetic workflow decreases, decrease the RAS activities, and kidney cause natriuresis and volume depletion. And also there is a natriuretic peptides, like the BNP is increased, so vasorelaxation also cause the volume loss. This is how it should be differentiated from the SIDH, but discovery of the SIDH existence is very dubious, because this is very old diagnosis when the SIDH was not known, but still it is slightly different from the classic SIDH we see together, but it should be differentiated as well. So most common of the hypervolemic ones are the fluid retention, secondary hyperaldosteronism, as well as reduced sodium excretion. Loss of plasma protein reduce the effective circulatory volume, as well as activating the counter-regulatory mechanism also cause the hypervolemic hyponatremia. Euvolemic one of our current importance is that most common cause of hospitalization actually the euvolemic hyponatremia. Other twos are rarely seen nowadays. So most common, it should be excluded before considering the SIDH is a hypothyroidism. Severe hypothyroidism can present with this kind of euvolemic hyponatremia, untreated ones. The adrenal insufficiency definitely can cause euvolemic hyponatremia, primary polydipsia or psychogenic polydipsia. Patients which are concerned, patients who are compulsive water drinking, psychogenic issues, they have also can cause euvolemic hyponatremia. That should be differentiated from SIDH. I will discuss later how to differentiate. SIDH most common causes are euvolemic hyponatremia with diverse etiologies. SIDH again can be of very different issues, be it from the brain tumor, lung tumor, be it from the drugs, be it from the many other causes. Usually associated with high urinary sodium, that is the very important differentiating mark. Unless the patient has water restriction, then again the sodium level excretion less than 20. Otherwise, most of the time SIDH has the sodium is more than 40. Hypothyroidism, very important DT, also cause raised vasopressin concentration and inability to excrete the free water as well. So that should be excluded for diagnosis of the SIDH. And again, very severe hyponatremia can happen in the very vigorous exercise and documented in the marathon runners as well. So physiological cause of euvolemic hyponatremia persists. You have to take the adequate history of the patient as well. So actually the SIDH is a misnomer. What it should look called for is the syndrome of inappropriate secretion of the antidiuretic hormone. It is not the inappropriate antidiuresis. So plasma vasopressin concentration is not always elevated. Remember that it can be of many pathogen patterns, but so it is not always elevated, and plasma ADH concentration may be elevated in numerous causes other than the causes of hyponatremia as well. So not if you find the ADH level elevated, this is not always the SIDH you think of. It is a balance loss which precipitates the SIDH. In normal people, ADH is suppressed once the plasma osmolality less than 280, the ADH regulation is impaired, is caused the SIDH. Normal people, it is suppressed, it goes below 280 or sometimes it is 270, ADH secretion suppressed to balance the increased water excretion. But if it is not so, the chance of SIDH occurs. There are 4 distinct patterns. Just to give you a nutshell, there are elaborate details as well. Type A is the unregulated release of ADH with no relation to the plasma osmolality. So it is independent release of the ADH. Type B is the modest and constant leak of ADH. So it is modulated by the plasma osmolality, but slightly elevated secretion persists even in the lowest osmolality versus the highest osmolality. So the slight leak persists. Type C is the downward resetting of the osmostat. So it is the osmostat resetting. Sodium level is stable, lower than the normal. So it is not so severe hyponatremia develops. It is very important to differentiate the type C because patient will not go to the severe hyponatremia. Most of the patient remains, sodium level remains 130, and that is the reset osmostat. Sodium level remains stable. If you raise the sodium level, it increase the ADH secretion and end up in more water intake. But this patient does not cause the sodium level fall below 125 at least. Preferably, it mostly remains around 130. So it is acceptable. So it is not required treatment sometimes. Type D is the least common one. This is osmoregulation is normal, yet the urine concentration is suppressed. At the urine is concentrated at the separate ADH because of the response to ADH, the receptors we have seen in the previous slides, the V2 receptor, which is mutated. So it is constantly stimulated even if the absence of the ABP. So, or it can be post-receptor defect of the aquaporin 2 trafficking. All of them can cause persistent activation of the system and cause the concentration of the urine even if the absence of the ADH. So it is suppressed ADH, but you have the SIDH as well. So there are 4 types. There are type E as well. There are mutation in the other response. There are type E, that is very least common. I'm not discussing that. The Barrett-Schwartz diagnostic criteria is oldest one and maybe the more classical one. So you should be remembering when you diagnose the SIDH. Decreased measure of the serum osmolality less than 275. Sometimes it is called 280. Clinical euvolemia or urine osmolality, as I said, more than 100 in spite of serum osmolality less than 275. Urine sodium excretion more than 40 with the normal dietary sodium intake. So patient is not restricted water intake or restricted sodium intake, then still the urine sodium excretion is more than 40. Normal thyroid and adrenal function, as I said, these are the very important differentials for euvolemic hyponatremia. normal renal function, because the CKD again cause alteration of the sodium levels as well. Exclude the other diuretic agents within week which is started. But if this patient is taking for months together, maybe the diuretic is not important for precipitating the new onset hyponatremia. No hypokalemia, no acid-based disorder, because if there is an acid-based disorder, that can be a different disease and that can also cause hyponatremia. So blood pH may be done if you have suspecting others and patient has associated hypokalemia. Supporting diagnostic criteria of SIDH is uric acid less than 4, blood urea nitrogen less than 10, sodium excretion FeNA, that is called more than 55%, or sodium fractional excretion is more than 1%. These are all supportive diagnostic criteria. Improvement of hyponatremia with fluid restriction. That is again important supportive diagnostic criteria, because most of the time mild hyponatremia can be corrected with fluid restriction and protein diet that maintains the solute load and correct the hyponatremia mostly. There are numerous causes. We can see that SIDH, the table is full and maybe sometimes difficult to see. But just to give you the broad classification, to remember that the CNS disturbances like stroke, hemorrhage, infection, trauma, anything can have. And that time sometimes maybe subtle, so may not be detected properly. And then psychological issues as well. As I said, the compulsive water drinking can also cause SIDH. Malignancies, it's mostly the small cell carcinoma of the lung and other small cell tumors anywhere in the body. Extrapulmonary small cell carcinomas, olfactory neuroblastoma, head and neck cancers, all these can cause this. Pulmonary disease like pneumonia, atelectasis, pneumothorax, hypothyroidism, hyperthyroidism, hormone deficiency, both are important, adrenal insufficiency as well. HIV is a very important presentation, so it should be excluded. Hereditary SIDH is a small fragment where the patient has a nephrogenic syndrome of inappropriate SIDH because gain of function mutation of the V2 receptor is there. We are discussing the V2 receptor. We remember when we discussed the physiology that gain of function receptor persistent activation can also cause hereditary SIDH. Family history is again very important. TRV4 gene encoding in the component of the central osmolarity sensing receptor in the hypothalamus can also cause hereditary SIDH as well. So maybe in the receptor level in the V2 receptor or the osmoreceptor sensing the TRPV4, all this can cause actually the SIDH hereditary form. So family history in the extreme rare though can be taken in the SIDH if it is documented. Idiopathic exercise associated hyponatremia, as I said, in the marathon runners, primary polydipsia, low dietary solute intake, sometimes the binge water intake or maybe the beer intake maybe can cause the hyponatremia as well. Drugs, there are lots of drugs can cause. Older drugs of the anti-diabetic agents, chlorpromide, fortunately not available, but other drugs like carbamazepine, valproate, vincristine, vinblastine, haloperidol, amitriptyline, even the opiates, even the vasopressin, oxytocin, exogenous administration for other reasons can also cause this. Bromocriptine, even the drugs as simple as ciprofloxacin, amiodarone can definitely cause the hyponatremia precipitated by the SIDH. So SSRI is very commonly used in the elderly middle-aged people like fluoxetine, sertraline, can also cause the SIDH. So take the very good history of the drug intake to exclude the pathogenesis of the SIDH of these patients. Most common causes are malignancy, pulmonary disorder, CNS, as we have discussed. Any CNS disorder may be responsible for non-specific irritation, decreased inhibition, or pulmonary hypercarbia associated with the increased ADH in the humans and hypoxia in the animals. SSRI, as I said, is a very important association. AIDS or treatment of the AIDS can also affect the tubular toxicity, precipitating the SIDH. Volume status should be ascertained. As I said, diuretics, especially thiazide, should be discontinued, and daily sodium intake should not exceed 5 to 6 grams. As a criteria we have discussed, should be evaluated on that background. Precipitation estimation is not reliable. As I said, it is very fragile hormone and very difficult to measure. And even if the vasopression is elevated, there are many other causes cause ADH elevation, and it does not prove the SIDH. The reverse is also not true. That suppressed ADH does not exclude the, as there are mutation in the receptor, as I said, that also causes SIDH, but vasopressin level is suppressed. So how to approach assessment of true hyponatremia, whether it is true or pseudo hyponatremia, very important to exclude. Hyperlipidemia and other issues can, serious hyperglycemia can also cause hyponatremia. Assessment of the true osmolality, calculated values have pitfalls. So usually if you have doubt, you'd calculate it first, then send it to the lab to confirm the true osmolality. And urine sodium excretion is very important. Chloride maybe have sometimes cell, and urine chloride less than 20 is suggestive of persistent vomiting. That should give you an idea. Blood gas analysis, alkalosis, acidosis should be excluded. Fractional excretion of sodium, as I've said, more than 1 or excretion more than 55% is important. Uric acid less than 4 is due to increased uric acid excretion in the urine result from the reduced proximal sodium and uric acid reabsorption. So that again, an indirect surrogate marker of that. In hyponatremia due to SIDH, blood urea nitrogen is also less than 5. So these are the very important factors. So this is the functional uric acid excretion, uric acid into creatinine by uric acid serum into creatinine in the urine divided by into 100. This is the fractional uric acid excretion. It is less. It is more, and levels are less in this patient. Copeptin is a very important marker nowadays for detecting the ABP secretion, because it is a 39 amino acid glycosylated peptide of the C-terminal segment of the ABP precursor peptide. It is a stable ex vivo, which is not in the ABP. Its samples can be stored over 7 days in the room temperature, and the correction of the sodium osmolality can be stronger for copeptin and then the ABP, because ABP is very fluctuating and changes rapidly, so that the osmolality correlation is stronger with the copeptin. So maybe the copeptin is easier to measure and the more stable diagnostic criteria for ABP surrogate markers maybe. Peptides level in healthy bulletins are strongly correlated with each other. So correlation point is very good. As I said, the cerebral salt wasting should be differentiated from the SIDH. So hyponatremia is there both. Sodium is both high, but extracellular fluid volume is increased in the SIDH, and cerebral salt wasting, it is decreased. Blood pressure is sometimes low in the cerebral salt wasting, which is not so. Blood urea creatinine, blood urea nitrogen creatinine ratio, both are high or in the cerebral salt wasting, which is not so in the SIDH. SIDH requires mostly the fluid restriction. On the other hand, normal saline infusion is required for the cerebral salt wasting. So this is the algorithm. Very difficult to read maybe for you, but you have the slides later. So confirm the hypotonic hyponatremia, exclude the hyperglycemia and other causes. Then acute severe symptoms are there. Consider immediate treatment with the hypertonic saline. That is a different story, but it has its own risk. So do not correct it more than 10 to 12 in 24 hours time. So urine osmolality is less than 100. So consider primary polydipsia, low solute intake or BI protomania. Or if the urine osmolality is more than 100, then we consider urine sodium concentration. Urine sodium less than 30 is a low effective arterial volume. That is heart failure, liver cirrhosis. If the extracellular volume is reduced, then we can look for the diarrhea, third space collection of the fluid, or the remote diuresis. If the urine sodium is more than 30, consider diuretics there or not. And if it is not there, then should the extracellular volume is reduced, then we look for the vomiting, primary adrenal insufficiency, cerebral salt wasting, and other causes. If the extracellular fluid volume is normal, then we look for the SIDH as exclusion. But before that, we exclude the hypothyroidism and secondary adrenal insufficiency for diagnosis. So this is in nutshell how we treat them. Management, as I said, whether it is acute or chronic, more than 48 hours or less than 48 hours is very important. Volume status, whether it is euvolemic, hypovolemic, and the extent of hyponatremia, it is less than 130, less than 125, less than 110. So all this situation matters. The patient with neurological symptoms with the serum sodium less than 125, prompt therapy with hypertonic saline, it averted significant brain edema and beneficial impact over morbidity and mortality has been documented. So we have either way, we have to prevent the cerebral edema, but very rapid correction has a chance of osmotic demyelination syndrome as well, ODS. So we should be slow but steady correction of the sodium to avoid either of these two. Casualty must be searched. If possible, offending drugs should be stopped. So look for the other drugs we have discussed for the hyponatremia and should be stopped. So just options, we look for isotonic saline as a 154 milligram, 310 milliosmol per liter. That is the components. Either of these two can be given. Hypertonic saline is preferred in the acute situation. Fluid restriction is definitely indicated. AVP antagonists are used in the mostly the chronic or the extreme cases. Democlocycline, lithium, furosemide, sodium chloride can be other options for treatment. Isotonic saline can be used as well because 0.9% sodium is typically used in the setting of the hypovolemic hyponatremia. So if there is a hypovolemia present along with the SIDH, it is better required. The rapid correction with increased risk of ODS is a concern, so it should be slow. Serum sodium urine output should be followed meticulously first 24 to 48 hours. Ineffective in the euvolemic patients, then we go for the hypertonic saline. Should be employed in the acute hyponatremia when the prompt rise of sodium approximately 2 to 4 millimole per liter, thus averting the brain edema and ICP further. Infusion rate is dubious, but mostly it should be slow. That is a recommendation. Not to correct the serum sodium more than 0.5 millimole per liter per hour, or that is 12 millimole per liter per 24 hours. Lower the case in case of risk of ODS, typically 6 to 8 millimole per liter in 24 hours. So if the patient has a developing risk of ODS, correction should be less than 10, or otherwise it should be targeted around 12 millimole in 24 hours. Fluid restriction should be employed very importantly, but mostly in the mild hyponatremia, it corrects mostly. Not recommended in the presence of severe or profound hyponatremia because it does not work and we are losing time for that. Mostly the restrict all fluid, not the water. Commonly, we tell the patient that you stop the water drinking, but other forms of fluid, be it juices, be it other liquids, even the dal or other forms in our country have adequate amount of fluid that should be restricted as well. Fluid restriction aims to 500 ml below the 24 hours urine output. So intake output chart should be monitored for the patient. Do not restrict the sodium or protein intake unless indicated for other reasons. So actually high protein diet is recommended along with the fluid restriction to get a good outcome. Urine osmolality is what are the predictors of failure? That is very important. High urine osmolality, even with the hyponatremia, is the indicator that you are going to fail. And urine to serum electrolyte ratio more than 1, it suggests that we are persistently losing the electrolyte in the urine. 24 hours urine volume is low, that is 1.5 liters. So restriction does not work because patient is also dehydrated as well. And increase in the serum sodium concentration less than 2 millimole per liter in 24 to 48 hours is the fluid restriction less than 1 liter per day. If it still does not achieve the sodium concentration rise by 2 millimole, it is preferably it is likely to be failure. So we stop that procedure. Democlocycline, lithium render the collecting drug resistance to vasopressin, thus increase the water excretion. But it has other side effects like can cause nephrogenic DI. Evidence base is lacking, so it is not commonly used. AVP antagonist, it is currently available maybe for last 1 decade almost. So directly block the vasopressin mediated VT receptor activation. Contraindicated in the hypovolemic hyponatremia. Very importantly, we commonly see as a patients ITU. So most of the patients were given AVP antagonist, not looking for the pathogenesis or the pattern like hypovolemic hyponatremia. It can precipitate the euvolemic or hypervolemic hyponatremia in this situation. So please try to correct the diagnosis yours. So avoid the hypovolemic hyponatremia to be treated with AVP antagonist. Hyponatremia with heart failure, not severely symptomatic, not responding to fluid restriction, Dapton therapy can be employed in the restricted senses, but should be careful and observant. And although not contraindicated in the decreased renal function, these drugs lose effectiveness if the creatinine level more than 3 milligram per deciliter. So should not be used in the creatinine more than 3. chance of ODS is there, and the strict sodium monitoring should be done at 6 to 8 hourly basis, at least initial 24 to 48 hours, to avoid the development of osmotic demyelination syndrome. But it's very costly drug. Maybe costs have slightly decreased in the last few years, but still we cannot afford it for more, and mostly the data is not available for more than a year therapy, so it cannot be used indefinitely. Conivaptan, first approved by US FDA, first Vaptan for IV administration. It is initially as 20 milligram loading dose over 30 minutes, followed by the continuous infusion, but it is not available here. Maybe good tolerability with slight side effects should be remembered, that headache, thirst, and hypokalemia should be looked for. Tolvaptan is available in our country. It's oral selective non-peptide V2 receptor antagonist. It's patients with serum sodium less than 125 eligible for the primary therapy. If serum sodium is higher, only indicated if the symptoms is attributable to the hyponatremia. Food restriction should not be used in the active phase correction to prevent the rapid correction. Again, you do not use fluid restriction with tolvaptan, that can rapidly correct the sodium level and end up in osmotic demyelination. So it should be kept in mind when you treat the patient. Other modalities like urea, mode of action is correcting osmolality not only by increasing the solid free water. It can be given 15 to 60 milligram per day, not commonly available, but limitation, again, dissolving the orange juice to mask the taste, because urea is very bad taste. A chance of azotemia is a very serious concern, should not be used unlimitedly. Furosemide sodium chloride may be a chance taken when the rapid volume and correction, volume depletion along with the sodium main retention. So use of furosemide 40 milligram per day coupled with the high sodium intake 200 milliequivalent per day can be employed in the select acute hyponatremia, but again should not be used for long. Follow-up management. In the patients of deviant body composition, use weight-based infusion volume rather than the fixed 150 ml. Correction of the hypokalemia results in increase in the serum sodium as well. So correct the hypokalemia if it is there. Follow-up management. Total body water calculation should be done. Fraction fracture 0.6 for the non-elderly male, 0.5 for the non-elderly female, 0.5 for the elderly male, and 0.45 for the elderly female. So change in the sodium correction, infuses sodium minus serum sodium by total body water plus 1. So this is the simplest way to calculate is achieve is to rise 1 millimole per liter per hour in the Archimedes formula. Moderately severe symptoms, immediate treat to is less profound, provided to prevent the further decrease rather than the rapid correction is more important. So if it is more than 125, it's better to maintain that situation and slowly correct it and try to not to fall below that. Time to diagnose, testing, and diagnostic treatment is very important. And serum sodium should be monitored at least after 1 hour, 6 hours, and 12 hours to monitor the titration. It is usually aimed to go for at least 5 millimole per 24 hours increase in the serum sodium concentration. Cause-specific treatment is very important. And first treatment may be infusion of 150 ml of 3% sodium chloride over 20 minutes, or preferably 30 minutes for the slower infusion to get an initial correction of the moderate to severe symptoms of the hyponatremia. Acute hyponatremia without moderate to severe symptoms, then adaptation has not occurred, therefore ODS is less concern. We can go for more rapid correction. It is the acute decrease in the serum concentration exceeds the 10 millimole per liter. We recommend single IV infusion of 150 ml of 3% sodium chloride over 20 minutes. So that is a rapid correction, and starting from diagnostic assessment should be done. Checking the serum sodium concentration after 4 hours using the same technique, and then repeat the treatment if possible. And chance of ODS, remember this, much less than the acute hyponatremia. Chance of ODS is much less compared to the chronic hyponatremia. What if the corrected too rapidly? Dramatic consequences, as we all concerned of, is ODS. Other rapid correction occurs, volume depletion with renal capacity to excrete the electrolytes, like the volume depletion in hypovolemia, treating the glucocorticoid deficiency, withholding the thiazide. These are the all potential measured hyponatremia correction too rapidly where it can be prevented. Lowering the fluid intake in primary polydipsia, again, that corrects it. So this is the diagnostic and therapeutic actions. Hyponatremia in the geriatric population is another concern. Hyponatremia without symptoms are fairly common. So elderly patient more than 70 patient may not have symptoms, but sodium level you can find it 126, 125 sometimes. Significant morbidity in the frail population, increased risk of ataxia and fall because disorientation, confusion is very important. There are diverse etiology. Aging itself can abnormality in the sodium regulation and secretion of vasopressin. Drugs are more common, as I said, SSRIs. Hypopituitarism is also more common in the geriatric population compared to the normal age, middle-aged or young people. Ketose hyponatremia is a low salt and protein diet, but excessive water, again, that can cause hyponatremia depending on the diet. Malignancies and CNS events are more common in elderly compared to the normal population. There is, as I said, treatment is depends on this presentation. Acute hyponatremia correction is more rapid. Chance of ODS should be kept in mind. Even in the elderly, in my opinion, we have seen that tolvaptan use may be sometimes required because the body's response to ADH is altered. It's safer to initiate in the lower dose. In hyponatremia in elderly with the diagnostic uncertainty, low dose hydrocortisone sometimes may be given because underlying subtle adrenal insufficiency again is very common in the elderly population. We should try to correct that, and as well as hypothyroidism should be looked for in this population. Neonatal, very uncommonly seen. I'm not going to discuss much. So in the serum concentration less than 133 is considered that may have the adverse outcome in the neurologic sequels or cerebral hemorrhage. Acute hyponatremia within 48 hours may be fatal, and moderate to severe hyponatremia may need treatment. And acute forms, rapid correction with 3% sodium chloride should not be used. Some things it should not be used in the very low body weight asymptomatic babies because rapid correction again can damage the immature brain. It should be monitored every 2 hourly. And there are pediatric causes. I'm not going in details of these. Again, management mostly the same. Hyperglycemia should be excluded. Decay and other things should be excluded. Pregnancy, again, an important concern. The sodium level less than 130, hyponatremia in pregnancy is documented, mostly because of anorexia, lethargy, apathy, and disorientation, confusion is associated with it. Mostly the intake output chart is very important because dehydration is a very important concern in pregnancy. So the take-home message is hyponatremia is a common occurrence. SIDH is the most important cause of the hyponatremia, maybe as we see, but before that we need to exclude others. Hyponatremia can be diverse features across various ages and population we have discussed. Hyponatremia, again, associated with significant short as well as long-term morbidities. Diagnostic approach of the paramount importance, and always risk-benefit balance is to be done between cerebral edema versus ODS. Acute cases need prompt correction, whereas for chronic ones, slower correction is necessary. So that is important to remember. With this, I end my talk. Thank you very much. Over to the organizers.
Thank you so much, sir. Thank you for giving such an enriching talk with such a beautiful presentation that you have shared with us today to make us understand the topic better. Thank you so much for that. We have received few questions, sir. With all your due permission, I would like to put across those questions to you. Yeah, so the first question is, what are the potential complications and long-term implications of SIAD, and how should follow-up and monitoring be conducted for affected patients?
What I mean to say is that long-term consequences, as I said, mostly the brain damage. Hyponatremia, in the long run, it's not compatible to life. So it causes significant disorders. Even as I said, significant hyponatremia can end up in coma and seizure. So these are the very important concerns. So as I said, in the elderly, which is of more concern because they have developed recurrent hyponatremia and may not be because of the SIDH. SIDH is correctable and we definitely treat the patient with the drugs we have discussed. tolvaptan, but again, the data is limited with the tolvaptan more than 1 year therapy. So we cannot guarantee that, but we may go for the drug holidays intermittently or adequate sodium intake in the diet. Up to 3 to 4 gram intake of sodium. Excess salt intake in the diet can be recommended if the patient is not significantly hypertensive. But honestly, sodium level, oral salt does not significantly affect the hypertension in most of the patients. So it can be added in a simple way. Take ORS electrolytes, a very simple way. Everyone can get access to it regularly to avoid the drop in the sodium level, because if the pathogenesis or the symptoms are different, and the elderly patient, these are all I'm talking about is the recurrent hyponatremia. To avoid the recurrence of the hyponatremia, these can be considered. Maintain the sodium level routinely measured at least once in a month or once in 2 weeks time. If the patient has recurrent hyponatremia in the few months time, so at least once in a month afterwards in the regular follow-up to avoid the complication. Patient caregiver should be looking for the telltale signs like disorientation, confusion, altered behavior, to detect the early signs of hyponatremia before it goes too low, below 125. And as I said, offending drugs, again, like the SSRI is a very important association. Other drugs which cause this, if it is documented, like the thiazide diuretics, should be avoided in the elderly or middle age who have the recurrent history of hyponatremia. So with this, this is maybe my way of looking at it.
Thank you so much, sir. Thank you for answering that question. We will take up the next question that we have received. And the question is, are there any recent advancements in the understanding or treatment of SIAD that doctors should be aware of for providing the best care to their patients?
As I said, copeptin is one of the way to detect the equivalence of the ABP, because ABP measurement is very difficult. Most of the labs cannot do it, and transport is difficult because it is a fragile peptide. So copeptin is a very important surrogate marker. Saline load test can be considered, but again, it should be in-house process. But Vaptans, like vitreoreceptor antagonists, are the recent therapies. But again, the long-term studies, more than 1 year, is not available, but they can be safely used, but with caution. As I said, do not start the sodium Vaptan with the fluid restriction that can rapidly correct the sodium level and end up in trouble. So too fast is not good for them. So if you use the Vaptan, start it slowly, start with a lower dose, and sometimes give a drug holiday in between. Okay, in my step.
Thank you so much, sir. Thank you for answering that question. That was the last question for today's session. And at the outset, I would like to thank all the viewers for their ardent participation that they have shown to us by staying tuned. And I would also to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights upon the topic, sir. Thank you so much. With all your last comments, sir, we can conclude the session here today.
Yeah, thank you very much for giving me the chance. So I end my session here.